I want to talk to you today about TAVI, Transfemoral Aortic Valve Implantation. It's also known as TAVR, Transfemoral Aortic Valve Replacement. This is a treatment that is designed primarily for patients with a condition called aortic valve stenosis. The aortic valve is the last valve through which blood flows before it goes around the body. Valves in the heart prevent blood going the wrong way. But sometimes when those valves become thickened and calcified, they just don't open properly. And aortic valve stenosis is a condition where the valve is not opening properly. When a patient develops severe aortic valve stenosis and becomes symptomatic with breathlessness or chest pain or dizziness or the beginnings of heart failure, then the time has come to perform some kind of treatment to relieve that aortic valve stenosis, to allow blood to flow freely through the aortic valve. At the moment, the TAVI is showing great promise, and it's particularly good in older patients who may not be suitable for surgical intervention, and in whom, in the old days, we couldn't treat effectively. But the problem with TAVI is that we still don't have good long-term data to assess the durability of the TAVI valve. In addition, when we put a new TAVI valve in, we pass the valve through the old calcified valve and push the calcified valve out of the way. And the seal around the edges of the new TAVI valve and your native calcified valve can be quite poor sometimes. So if you've got mild or moderate leak particularly, then the long-term result with that outcome is not as good as if you didn't have any leak around the edges of the new valve at all. Now, the third problem with TAVI is, of course, that because we push this calcium out of the way to put the new valve in place, this calcium pushes out into the soft tissues around the aortic root. And the aortic root is where the aortic valve is hanging. That calcium can injure a conduction system within the heart, which is the normal electrical supply. And this means that you have a higher risk of needing a pacemaker. So that after surgery, the risk of pacemaker might be 1 or 2%. With TAVI, it can be high as 10%. And we know that if you end up with a pacemaker, then that will reduce your long-term lifespan. Now, the traditional treatment is surgery, aortic valve replacement. And it remains the mainstay of treatment because what we can do as surgeons is cut the old valve out and put a new valve in, either stitch it in or blow up a balloon to hold that valve in. And the beauty of that treatment is that it's very reliable. It means that there's going to be very low risk of leak around the edges of the new valve. We know predictably how long the valve will last, and also the risk of needing a pacemaker is not particularly high. So knowing all of that about traditional surgery and TAVI, we have to create a balance. Traditional surgery does have drawbacks. It needs an operation. The traditional operation is a breastbone. We need to use a heart-lung machine. So if you're older, frailer, with perhaps kidney dysfunction and lung dysfunction, then TAVI might be a better solution for you. You don't need the surgery, you don't need cuts, you need maybe a light anesthetic, and you don't need to go on the heart-lung machine. But if you're a younger individual where the long-term outcome is really critical, then you're better off having surgery. And in a 65-year-old man who's fit and well, we wouldn't want to put a TAVI in that patient because we don't want to leave that individual with leaking around the edge, a valve where the durability long-term may not be completely understood, and also a higher risk of pacemaker. Now, what is beautiful is that newer style pigs and cows valves, particularly the newer style cows valves, are very durable. But in the event that they wear and tear, we will almost certainly be able to put TAVI in those valves with the protective influence of the ring of the tissue valve that we put in some years previously. So this is now becoming a much more frequent approach to patients who are a little bit younger, in whom avoidance of a mechanical valve is the preference because many young patients don't want to be on a blood thinner, which is what you need if you have a mechanical valve. And then down the line, having had a beautiful operation first time round, when they're older, perhaps a little less fit, if that tissue valve wears and tears, we can use TAVI. Now we can do that today, but 10, 15, 20 years from now, the newer TAVI technologies will be far more superior than the ones we have today. Now, the guidelines generally say that under the age of 65, surgery is the right treatment. But again, that's a balance. If there's lots of other morbidities, it may not be the right option. Similarly, over the age of 80, TAVI might be the right option, but a patient may not be suitable for TAVI, but otherwise fit and well. And so surgery might be the right option there. Now, between the ages of 65 and 80, generally on the whole, decisions are made in part speaking with you as a patient to understand what your preferences might be. But as doctors, we have to come to you with what we think is the best solution to allow you to make an informed decision. And the way we do that is that we have a multidisciplinary team of individuals, expert cardiologists, expert surgeons, both with minimally invasive and TAVI experience, who will look at all of your data and look at your storyline and work out for you what would be the best treatment for you.